On behalf of the WBMT and the EBMT, I'm very happy and honored to be able to present our study during this ASH meeting. I'm presenting on behalf of Professor Amin BEEKADJA, who is actually the principal investigator of this study, but who cannot make it to ASH today. So, as you are very well aware, to perform autologous stem cell transplantation in myeloma, we collect peripheral blood stem cells, and these cells are cryopreserved. However, in some countries, they are not, and we call them non-cryopreserved PBHSC, and some preliminary experiences have already been reported, and actually by the first author in lymphoma, with positive results. So the goal of this study was to check whether or not non-cryopreserved could be an alternative to cryopreserved PBHSC to perform autologous stem cell transplantation in myeloma. So the primary endpoint is the engraftment, both the neutrophils and the platelets, and the secondary endpoint is the non-relapse mortality between the two procedures. So this is a retrospective international multicenter match pair analysis, as you will see, between a huge center in Algeria, in Oran, where they performed the non-cryopreserved auto-transplant, and we compared with the EBMT database from 23 countries. Initially, we had 437 adult patients, myeloma adult patients undergoing a first upfront myeloma autologous stem cell transplantation between the year 2009 and 2020. Mobilization was done with GCSF alone for 5 days, and stem cell collection was done with either COB Spectra or Optia standard protocols. And the conditioning regimen was either melphalan 140 or 200 milligram per meter square. So this is quite simple. PBHSC were collected and stored in a fridge at 4 degrees Celsius for 24 hours. Right after stem cell collection, melphalan at a myeloablative dose was given, either 140 or 200 milligram per meter square, and 24 hours later, the stem cells were reinfused. So the methodology followed a pair match analysis, and for each non-cryo patient, we match it with 4, we tried at least with 4 cryopreserved patients, and we matched for the 7 parameters that are shown here: the sex, the myeloma phenotype, the disease status at transplant, melphalan dosing, 140 or 200, interval from diagnosis to transplant, and date of transplant, and age at the date of transplant. So we were able to make an exact matching for the first 4 variables, and for the other 3, we use a propensity score matching. The crude cumulative incidence estimator with death as a competing event was done for the cumulative incidence of engraftment, as well as the non-relapse mortality. Groups were compared using Graves' test. We had data for 405 patients, and 19 could not be matched for different reasons. So in the end, we studied 386 non-cryo patients that we matched, as you can see here, with cryopreserved patients. Patients were relatively young, 55 years for autologous stem cell transplantation in myeloma. The induction regimen for the non-cryo is shown here. It's quite heterogeneous, but more than 95% had Velcade bortezomib-based regimen. 3/4 had only one line of induction treatment prior to the transplant, the auto transplant, and 1/4 needed a second line. The median number of collection procedures in the non-cryo was 2. And as you can see, the median dose of peripheral blood stem cells collected was similar in the two cohorts, around 10 times to the 6 CD34 cells per kilo. The average non-cryo PBHSC viability at the time of collection was 95%. And here is the most important slide. As you can clearly see, there was basically no difference in terms of neutrophil engraftments, 12 days for the non-cryo and the cryo, and the platelet engraftment defined as over 20,000 per millimeter cube between the non-cryo and cryo 13 days. And in terms of non-relapse mortality, as you know, this is a safe procedure, auto-transplant in myeloma, and 0.8% in cryopreserved and 1.3% in non-cryopreserved. So in conclusion, this large cooperative study found that neutrophil and platelet engraftment rates were similar in the cryopreserved and non-cryopreserved matched cohorts. Moreover, there was no significant difference in terms of non-relapse mortality. This is the team from Oran, and we thank all the collaborators from the EBMT and the WBMT network. Thank you very much for your attention, and I'm glad to answer to any questions. Thank you.
Yes, please.
Hi. Sorry. Yeah, this is Miao Xu from Qilu Hospital, China. It's an interesting study, and actually it is striking to me that you didn't get any difference between these two groups, right? The non-cryo versus the cryo reserved. So for me, I feel like during this transplantation, like those without this cryo storage, so the platelet component within that transplant will be like far more compared to those were stored in for a longer time. So that will maybe increase, you know, the platelet engraftment. It will be easier for the platelet. I'm not sure whether you observe the component within your transplants, like the viability of the platelet.
No, we didn't specifically look at what you just mentioned, if I understand you correctly,
yeah,
concerning the platelet viability. That's what you asked.
Yeah, because usually we get less time for the platelet transfusion if we didn't store them for like for those non-cryo preserved.
I cannot tell you. In fact, we looked at that, but if there was more platelet transfusions, maybe in the non-cryo, is this what you're suggesting?
Yeah.
I cannot tell you, but we can check that. Yes.
May I ask a question? So, I think this is, as you mentioned, is very important for low resource or medium income countries, because there is no cryopreservation, right? So you said that you are infusing cell within 24 hours. What if you did not get enough? So is there a tolerance beyond 24 hours, or what do you do in those cases?
Yeah, that's a good point. Actually, the author published the same methodology for lymphoma. And as you know, lymphoma, the conditioning regimen is much longer, and he was able to keep the cells in the fridge for 5 days. So it gives you more flexibility to re-infuse these non-cryopreserved stem cells.
And how is the viability affected by keeping it for 5 days?
I cannot tell you exactly, but it was good enough because actually in the first slide in the journal Cryotherapy, Professor BEEKADJA published in lymphoma similar results with same engraftment both for platelets and neutrophils.
Right. So I think that would be interesting to see, because right now I think in the field the tolerance is perhaps maximum 72 hours. So we want to keep fresh cells within 48, but in some cases maybe 72. But if you are saying that particular study was able to demonstrate up to 5 days, that would be interesting to see. But the another point is sometimes we don't consider if you have more than the minimal dose of CD34 cells, even though you go beyond the maximum limit, you may still have a room for some deviation, unless you have a very marginal dose of CD34 cells. That could be
that's a good point. You may need, especially for lymphoma, target a little bit higher number of CD34 cells to be on the safe side.
Right, right. Is there any other question from the audience? Okay, thank you very much.
You're welcome.
We'll move to the